So our next presentation is by an orthodontist, though it's not really an orthodontic issue per se, though it certainly is involved in it. Our speaker, Greg Wong, is our chair of the Department of Orthodontics. But I like to use Greg as an example of the kind of person you want to get involved in clinical research, because he came, his training in dentistry was, I think, at Florida, and came to the U.S. for to the UW for training in orthodontics. Then he went into practice for 10 years, practice of orthodontics, full time, with a little dabbling, I think, with teaching down in Florida. But then came back to the UW, wanted to be a faculty member, wanted to do clinical research. Came in, we put him in a training program in which he got a degree in epidemiology. And what I liked about it is he came with a bunch of questions about the practice of orthodontics and dentistry that he wanted to address, and we gave him the methodology tools to be able to address that. One of the issues that he got involved in, and he can tell you how it came up, was the whole issue of third molars and what's going on. Do people recommend them? Do different groups recommend removal for prophylactic purposes or whatever? And so he developed this protocol for looking at third molar removal to understand what is actually going on out there as far as general dentists recommending or not to their patients, and then what happens after they make recommendations. Do they follow through? Are there consequences of what they do or do not do? So his title is Extracting the Evidence on Third Molar Management. So, Greg.
Thanks, Tim. You guys hear me okay? Yes, no? Yes? Okay. Thank you, Tim. So it's really a pleasure to be here. I just wanted to mention I'm just recovering from a cold, so hopefully my voice will hold out, but I apologize if my voice is a little bit scruffy. I also would like to just echo everybody's comments about thanking this group and the others who have participated in Northwest Precedent. It truly, without your help, without your efforts, without your patience, none of this could be possible. I was looking through my binder, and it lists all of the general dentists who participated in study 9. There's 50 of you, and I don't know that many of you, but again, I do want to thank each and every one of you and your staffs and the study coordinators for the regional coordinators for all their efforts. Now, before I start, a couple things I want to mention. First of all, Tim should know better where I'm from and what I've been doing, because he's known me a long time. Maybe I should credit all of my career to Tim, who actually taught me biostatistics way, way back. So Tim, thank you for that. And the second thing is, it really is not fair to pick on orthodontists so much. Now, Joanna, I was on the study with you, and you know in that systematic review, the amount of recession that we saw with orthodontic treatment was a fraction of a millimeter. I think it was something like 0.2 of a millimeter more if you had orthodontic treatment, okay? So statistical significance, clinical significance, sometimes you really have to use your judgment on that, okay? Now, having properly defended orthodontics, I think we can move on with the third molar information, okay? I think all of you know third molar removal is quite common in the U.S. We have data that shows 50% of insured individuals will have their third molars out by the age of 20, and the large majority of these are performed prophylactically. There's still a lot of controversy, as you all know. This is just some of the history of the controversy. In '79, a big NIH conference was convened. They really could not come up with any consensus on third molar removal. In 1996, an early review article by Daly said that 98% of third molar removal has no benefit. 2 years later, Amos came back and said, well, really all thirds are pathologic and surgical treatment is indicated. And in 1999, in the UK, their National Health Service concluded, after looking at third molar information, that there was no reliable evidence to support prophylactic removal. So, I mean, it just kind of keeps going back and forth. We're all clinicians here. I'd just like to take a quick poll. Here's a 16-year-old with 4 third molars. How many would recommend extraction in this patient? So maybe a little more than half. And you know, they all look like they're in pretty good position, right? And obviously the patient is asymptomatic. Okay, and here's my 18-year-old patient. How many would recommend extraction here? Almost the entire group probably would, right? And I think, you know, you're probably looking at this guy here and saying, well, that's not in very good position, and if we're going to get this one, we might as well get them all, right? And then here is my 22-year-old patient. Okay, and you can see that all 4 third molars have, well, 1, 2, 3, there's no one there. But those 3 have erupted and are quite in good position. And if you notice, the bone levels are quite good.
Is there any decay on those teeth?
No decay, asymptomatic. So I'll ask the same question. How many would remove these third molars? Not so many? Not anybody? I mean, yeah, at least a few, right? I mean, some of us just don't like thirds, right? So that's okay. But, you know, all 3 of these situations are what we see day in and day out, asymptomatic third molars. What are you going to do with them? Now, I thought it was appropriate because we conceived this study some 7 years ago. It's been in the works. Where are we now? I gave you a little bit of background. Well, very interestingly, just in July of 2011, in our orthodontic journal, American Journal of Orthodontics and Dentofacial Orthopedics, they have been running a series called Point Counterpoint. And the topic for that month just happened to be third molar removal. So this topic just keeps getting kicked around. And they had the point in favor of removal, was written by Ray White and Bill Prophet. Now, many of you will know Ray White is an oral surgeon at North Carolina. Bill Prophet is actually one of our UW orthodontic alums, but he's been chair at North Carolina for a long time, now as emeritus. But these 2 wrote the point to third molar management. You see their title, Evaluation and Management of Asymptomatic Third Molars. Lack of symptoms does not equate to lack of pathology. Now, here are their main points, and I want to stress these are their main points, not my main points. Okay, this is from their point counterpoint article. They said, symptom-free does not mean pathology-free. They also define periodontal disease as a pocket depth of greater than 4 millimeters around the 2nd or 3rd molars. Using that definition, they said that 65% of a cohort of 25-year-old patients had periodontal disease. 65%. And when they followed these people for another 4 years, another 10% developed a pocket greater than 4 millimeters in those teeth. So at the end of that 4-year period, at the age of 29, they're telling us that 75% of this population had periodontal disease. Now, they also go on further to state that these sites may initiate periodontal disease further anterior in the mouth. Okay? And of course, what's the simple solution is you extract the 3rd molars. You eliminate at least the 4 millimeter pockets around those teeth. And finally, they would say that if you extract after the 3rd decade of life, there's more complexity to extraction and there's more morbidity if you do the extractions then. Okay? So remember, these are their points. Now, on the counterpoint is a fella down in Australia. His name is Sanj Kandasamy, and he's just a little guy. I had a chance to meet him at a meeting recently, just a little guy, but he's really very brave because he is willing to take on all of Amos and any oral surgeon out there. And he wrote this, and here's what Sanj said. He said, periodontal disease, the relationship between periodontal disease and third molars is not conclusive. Sorry, there's a bug here, actually. And is greater than 4 millimeters of pocket depth indicative of periodontal disease? He asked, do we routinely extract any tooth with greater than 4 millimeter pocket? Okay. He asked, are extractions really easier at younger ages? And finally, he asked, how well can we really predict all these future problems that we are claiming to prevent, right? Well, Study 9, conceived some 7 years ago, conducted in the network setting of 50 offices, actually does, in fact, address some of these issues. Now, actually, I should mention a couple things. One is, you didn't see in the reasons for third molar removal in the point that, that Prophet and White were talking about lower incisor crowding, right? That seems to kind of be more or less resolved, and people are feeling like that's not one of the main indications for third molar removal anymore. So they didn't put that up there. But what you did see was that heavy emphasis on periodontal condition, right? And by the way, I don't know how many of you get some email updates from the ADA, but did anybody see just a couple days ago, there was an email alert from the ADA talking about the relationship between periodontal health and cardiovascular disease. Anybody see that? Yes, and what did they say? No connection. So very interesting that the oral surgeons have kind of jumped on this periodontal disease and systemic disease, but in fact, that was the Council of Scientific Affairs from the American Dental Association saying that they didn't really see good evidence that there is a connection there. Okay, well, again, back to Study 9. We actually do address some of the questions and the points that were raised in that point-counterpoint article. And, of course, we have followed patients for 2 years, which is challenging in this population. Later on, when I talk about white spot lesions, that was only an 8-week follow-up. And, you know, if you gave me the choice to do 2 years or 8 weeks, I can tell you which one I would pick in a heartbeat, right? So 2 years is quite challenging. But in fact, I would say that really 2 years is probably not even long enough. If I could have more time, I'd like it. And another thing I'd like to mention is we are just on the tail end of collecting this data. So we're really presenting preliminary data. I'm not presenting any p-values or anything like that. We still have some analyses to do with the complete data, and we still have some areas that we haven't analyzed all the data. So I apologize that we can't report everything, but because of this 2-year follow-up, it is quite difficult to get all the data in, and we want to get as much as we can. So you dentists out there that are still doing Study 9, please collect as many of those follow-up exams as you possibly can. Specific aims, we talked about your reasons for removal or retention. We will talk about adherence to recommendations by the patients. We'll talk about rates of paresthesia, Tmd, and pericoronitis over a 2-year period, and also assess caries rates and periodontal status after 2 years. Those were our original specific aims. In our study design, as I think most of you will recall, cross-sectional component for phase 1, we enrolled 16 to 22-year-olds, and patients were approached in conjunction with their typical 6-month recall visits. There was a clinical exam, including radiographs, and then all of you would make your recommendations on those teeth. And we collected some baseline information on caries, peristatus, Tmd, and again, the focus was reasons for the recommendations that you made. In phase 2, it was a 2-year web-based longitudinal study, and the idea was that patients would be contacted via email every 8 months to do an online survey. We did provide incentives, and we had iPods to give out, and we also gave out iTunes cards. And we wanted here to investigate adherence to your recommendations, and also to gather information on what the patients reported as the reasons for their actions. We also were able to get information on their self-reported complications over a 2-year period. And what we thought would be the beauty of this phase was it was not supposed to require any time from your offices. It was difficult sometimes to contact these patients, so I think ultimately we did ask some of the offices to help us in making contact and getting the patients to fill out these 8-month surveys. Phase 3, which is just about at the tail end, was a 2-year recall to assess caries, perio, paresthesia, Tmd. The subjects were recalled by the offices, again, supposed to be in conjunction with a 6-month recall visit, and we wanted to look at long-term. 2 years, as I said, is a pretty decent amount of time, but certainly if we could follow some of these patients even longer, we'd have better information. Okay, well, what about the results? I call this what you guys recommended, right? Phase 1. So I realize this is a little bit small, but I'd like to go through this table with you. What you have here is the patient's information, their age, and what you see is a total number of patients within each age stratum. You'll see that roughly about 75% of the patients were 18 or under. Okay? It doesn't probably surprise us because oftentimes patients will lose insurance after the age of 18, and we probably see less of those patients. As far as insurance goes, 10% had no insurance, 11% had Medicaid coverage, and the great majority, 79%, were covered by private insurance. Okay? And as far as gender, pretty equal. Just about 50% were recruited, males and females. Now, the final column I've put over here is your recommendation. How many from each of these strata were recommended for extraction? And you see here by age, it's kind of in the 50 to 60 range throughout the whole period. So not a whole lot of discrimination here. By insurance, interestingly, 62% with no insurance, 53% with Medicaid, and 59% with private pay. But again, not huge differences. And if you look by gender, about the same number. So basically, based upon this information here, there's not a lot of differentiation on who gets recommended. It's somewhere probably in the high 50s to 60%. I should probably also mention that about 92% of the patients were Caucasian. Now, as far as management goes, we asked all of you early on about your typical management strategy. And the idea was that we were kind of asking whether you always recommended prophylactic removal, okay? And about 22% of you said that was your typical management style, was essentially third molars were going to be out, okay? Another 70%, this is the largest proportion, said that usually you'd recommend extraction if the eruption path was poor or there wasn't enough space. And then finally, there was a very small proportion of you who said that you would only recommend extraction if a patient had existing symptoms or if there was pathology present. Only 6% of you were in that category. So this was kind of your philosophy, if you will. Now, we then looked at, based upon those philosophies, how many dentists fell into these, how many patients they had, and then over here, really, then based upon your philosophy, what was your batting average? What was your percentage of removal? So essentially, if you were in the camp to almost always recommend extraction, you were at 61%. And if you were extracting because there was a poor path or insufficient space, you're still about 61%. And here, this is really where you only see a big difference, is 6% if there was pathology or symptoms. But we had very few dentists really who fell into that category. Okay? But maybe we could have done a better job discriminating between these two philosophies because the outcome there was almost identical. If you look at gender, we have male and female, and we had a lot more male dentists than female dentists. And maybe the males recommend a little bit more than the females, about 60% versus 50%. Now, we get to your reasons for recommending removal. We had almost 800 patients total, and in about 60%, extractions were recommended. The most common reason, you guys may remember, we asked you what was your primary and secondary reason. So the most common reason for recommending removal was prevention of future problems. Okay? Prevention of future problems. So what could they be? Whether it's periodontal problems, caries, pathology, pericoronitis, prevention was the main reason. And the next most common reason was unfavorable orientation or unlikely to erupt. Okay? So maybe there wasn't enough space, maybe the tooth was rotated, but your clinical opinion was that tooth was not one that was likely to be functional. Look down here, pericoronitis, caries, and pathology. 4%, 4%, 1%. Okay? In less than 10% of these patients, you could argue, are they being referred for removal when they have some kind of pain or pathology? Okay? And insurance coverage, this was surprising to me. I mean, in a sense, it was only claimed as being a reason for getting third molars out by 1% of you. Okay? I mean, in a sense, that's good because we're recommending third molar removal for health reasons, not for reimbursement reasons, right? Now, what about reasons for retention? 40% of the patients were recommended for retention. The most common reason was it was simply too early to decide. Okay? And the next most common reason was that there's a favorable eruption path, so those teeth likely would come in, and they were recommended to be retained at that time. There were a few associations we found in this phase 1. We found that third molars would be more commonly recommended for removal if they had any degree of impaction or partial eruption other than fully erupted. Okay, so in other words, any impaction, anything less than fully erupted was more likely to be referred for removal. If any third molar was tipped more than 35 degrees, you were more likely to refer them for removal. If there was any caries in the second or third molars, and finally, if there was any pain around third molars, more likely to be referred. Probably what we would expect. Phase 2, I call this what patients did. And all of you treat patients, sometimes it can be very surprising to us what patients will do, right? So, first of all, again, about 800 patients, and we had less than 50% response from our patients and at the various times. So here you see at 8 months we had 380 responses, 377, and then 314, and still counting a little bit there. Oh, shoot. Well, sorry about this formatting issue. But here are the patient response to the recommendations. Okay, so remember, this is what the patients did. The first thing is, here's your recommendation. If you suggested that they retain their third molars, there was 200 patients like this, there was still 34 of them who went on and had their third molars out. Okay, so again, this is what I'm saying is, we cannot really control what our patients will do. And if, on the other hand, you suggested that they need to have at least one or more of their thirds out, only 55% of them had that performed during the follow-up period. So about half were complying. If I show you graphically what this looks like, in the red are the patients you said, keep your third molars. Well, you can see they still had up to about 16% removal at 30 months. And here, you told these folks, get your third molars out, and you can see they approaching 60% actually following your recommendations over that period of time. I know this is a little bit hard to see, but these tables are in your booklets. If you want to flip over to that page, these tables are reproduced for you. And basically, this is third molar removal by patient characteristic, table 2. If you look at gender, Females, and remember, this is what the patients did. The females, about 58% that were recommended had third molars out. The males, about 51%. Okay? By age, if you look at this, it seems like the 16, 17-year-olds had a little bit more third molar removal. It went down a little bit as they got older. By race, about the same. By dental insurance status, this is kind of interesting. If they had no insurance, 65% had their thirds out. If you had Medicaid, 67%. If you had private insurance, 53% had their third molars out. Eruption status, if it was, here's only one, we'll disregard that one. But if you partially erupted, only 36% had them out. If they were soft tissue impaction or hard tissue impaction, it was in the 50 to 60 range. Again, this is what patients did. Look at this. If the angulation was less than 35%, 60% of the people got their third molars out. If it was greater than 35, only 52%. So that's just opposite. We would have liked to see those greater tip teeth be extracted more often. And here, pain, no pain, 53%. If you had pain, 63%. And then finally, caries. If there are no caries, 55%. If you had caries, 48%. Okay? So again, these are not probably what you might expect, and I think just illustrates that we make our recommendations, but what the patients decide to do, we have much less control over. Now, I thought this part was the most interesting, is we asked the patients, well, why did you get extractions, or why didn't you? And look at this number one reason why patients give you for getting third molars out: availability of insurance coverage. Okay? Now, again, this is their report, so this is an interesting section. What I start off saying is we make our recommendations. We don't know what patients are going to do, and then we don't know how they're going to respond to surveys either. Okay? So we don't know what they're going to do or say. But that was their main reason: availability of insurance. 90% of them said that was the most, either the first or second reason why they sought to get their third molars out. And if you look at this, tooth not likely to erupt, that was the next greatest. And then it went way down, and I hate to tell you, look at this. Your recommendation was only 22% of the time cited as a reason they did what they did. Okay? I hate to be the messenger there. Prevention of problems, 10%. And look at this, pain, okay? Only 1%, and existing disease such as a cyst, only 7%. So again, here is symptomatic pain, pathology, less than 10%. Okay? Okay, now you ready for this? This is why they kept them. Okay? You'll like this. Look, if you told them they could keep their third molars, that was great. They listened to you. 89% of the people said that was the reason they decided to retain their third molars, because you said they could keep them. Other reasons: couldn't schedule time off, risks of surgery, these things. Here's a prior pain is no longer present. Well, that's almost 20% of the people saying that was their first or second reason. Okay? So again, some interesting things that we find out by questioning the patients. We also asked about self-report of paresthesia. Now, again, I'm sorry these are small. They are in your handouts there, so you do have all this information. They're not in the slide reproductions. You have to go actually to the section just after that. But here, if you look at no thirds removed versus thirds removed, okay? No thirds removed, we have 360 people here, and some of them reported paresthesia. A very small percentage, less than 1%. If you had your third molars removed, it was about 6.7%. So the odds of having paresthesia, about 8 times greater if you had your third molars out. Okay? And if we break that down into whether it's lip or tongue, for the lip, the odds are 22 times higher, and for the tongue, it's about 5 times higher. Okay? And I think we all know this. This is a real risk, paresthesia. What about Tmd, or Tmj symptoms? We also asked patients to report on this, and we asked them, after the normal healing period, after the couple weeks that it takes normally to heal, did you have any of these symptoms? Okay. And this is what we found out. Again, no third molar removal this area, and then third molar removal over here. If you look overall, any sign or symptom of TMD, we had 225 subjects, no thirds out. 59 of them reported they had a sign or a symptom. That was 26%. That was a lot higher than I would have expected. And if you had your third molars out, we had 114 of these people, 42 said they had a sign or a symptom, which was 30% of that population. Well, let's break this down a little further into those who reported a sign. By that, I would say jaw popping or clicking, but no pain. And what we see here, no third molar removal. The incidence was 20% reporting jaw popping and clicking. And if you had your thirds out, it was only 12%. Okay? But what I think is more important is pain. And so here we have pain on wide opening. In the people who retained their thirds, it was only 8%. In the people who had third molars out, 28%. And if we asked them whether they had pain in the temple, jaw joint, or jaw muscles, 9% if you didn't have third molars removed, 15% if you had your third molars removed. So if you look at either pain, the ratio would have been 12% versus 31%, almost 2.5 times more likely to have third molars, to have TMD symptoms if you had your third molars removed. You got to wait. Throughout the 8-month interviews. Okay, I will take questions afterwards, okay? So anyway, 2.5 times greater chance to have some kind of TMD symptoms, okay? All right. Now, the phase 3 results, as I mentioned, we're just at the tail end of collecting all this data, so I'm not presenting it all. We have a lot of data to go through, but here are some results from phase 3, which is the 2-year follow-up. We currently have follow-up data on 214 patients. Our target for this phase was about 300. Now, I did want to mention that our target numbers were based largely on I think TMD, because we were expecting the prevalence of TMD to be much, much lower than we thought it would. So actually, even though we haven't reached our target, we may wind up being adequately powered for the statistics later on. I wanted to mention that 92 patients had at least one third molar extracted, and 122 had kept all their third molars. We looked at periodontal status, and some of you may remember this chart here where we had several measurements made. One was to the depth of the pocket, another was to the CEJ, and then basically from that we could calculate attachment loss. We felt like attachment loss is really what we want to look at, not just the pocket depth, because you can always have some inflammation around third molars. So the data I'm presenting here is attachment loss at the distal sites of second molars. Okay? And here, the adjacent third molar is present. Here, the adjacent third molar is extracted. Let me walk you through this. At baseline, with about 900 sites, the mean attachment loss was about 0.5 millimeter at the distolingual and distobuccal of the second molars. When these teeth were followed up 2 years later, the mean attachment loss was about 0.9 millimeters. So during that time, 2 years, there was about 0.5 millimeter of attachment loss if the third molars remained. On the other hand, for those who had third molars out, at baseline, the mean attachment loss was about 0.5 millimeter, and at follow-up, it was about 0.8. So these had a mean attachment loss of about 0.2 during the follow-up time. This is when third molars were removed. So if you look at these numbers, 0.51, 0.22, both groups showed a little bit of attachment loss on average, and the ones that had third molars out seemed to fare a little bit better. Okay, now we haven't done any statistics yet. We're waiting to collect the whole sample before we run any statistics, but this is what we've seen so far with the data that we have. Okay. And if we look at caries, you may remember in that point-counterpoint, caries was not one of their main issues. And in fact, we found caries really, and this is at the distal of the second molars, we found caries to be really pretty infrequent. Only 2% at baseline, and 3% at follow-up, and really only about 1% new caries at the distal of the second molar. That was when the adjacent third molar was present. And if the adjacent third molar was extracted, here you see we had 5 at baseline. We had a total of 4 at follow-up, and we've really found only 1 new carious lesion. So if you're extracting to prevent caries on the distal surface of the second molar, probably not a big issue. Okay, well, how does this fit with existing evidence? I'm sorry, I'm looking at the clock here. I realize I'm running out of time, and everybody's probably hungry. So we really have had very little information on the dentist's and the patient's reasons for extractions. It is very interesting, I think, that insurance for the patients is such a big factor. Remember, 90% of them said that was the reason why they decided to have their third molars out. And this definition of periodontal disease by Amos, I actually went to 2 periodontal faculty at the UW to ask them if they agreed with that definition of periodontal disease, which is any pocket greater than 4 millimeters. And what they said to me, both of them said, periodontal disease defined by, number 1, attachment loss, and number 2, inflammation. Okay? And neither one of those are in the definition that the Amos is using. So that's kind of a, I don't know exactly how we should interpret their information. I think I'm going to skip this because of the time. Caries, again, as I said, has low risk. Attachment loss, on average, was minimal. Just a little bit more when you kept the thirds. But really, I feel like we need to investigate this for a longer period of time. And it is kind of a complex thing to look at how sites may heal or how these pockets may progress when thirds are either kept or removed. The risk for TMD symptoms, I would say, is supported by this data. That was one of the things we wanted to find out. Is TMD a potential problem when third molars are removed? And you could see that the risk factor was, relative risk was definitely higher. Well, next steps for us, of course, are to complete the data collection and the analyses, which we hope to do in the next couple of months, and maybe some further investigation into perio. We'd like to do some comparison of self-report and dental exam data, because we do have that. And, again, if we could follow up patients over a longer period of time, that would be great. Some quick lessons learned, I think, is that it's difficult for offices to conduct more than one study at one time. And I think we need to keep our study procedures always to a minimum and to think about the burden for the offices, because dental offices are busy places. In phase 2, what we learned is we have to really pay attention to changing technology. All these kids were not using email by the time we were implementing the study. They were all using texting and Facebook and Twitter. And also, iPods are essentially, within 5 years, they're a forgotten technology. Nobody uses iPods anymore, and that was our prize if you would participate. So that was a problem. In phase 3, again, I would just say that this population, 16 to 22-year-olds, is very difficult to follow up on, and you really have to make all kinds of measures to try to keep track of them. I'd like to thank all of you again, the regional coordinators, especially Marilyn, who really helped a lot with this study, the biometry corps, especially Chuck, who has been helping me a great deal for the past week and a half, just trying to get all this data analyzed. Axio Research, NIDCR, it's been kind of a labor of love to do a study like this, and I just want to thank all of you for your participation. So.
We are running about the end of the session, but I think we still should take just a few minutes for questions. I suspect there will be some.
You get to ask now.
I've got it here. Do you remember
Back here.
back in the 80s when the orthodontists decided that we should remove second molars and leave the thirds?
There you go, picking on
Do you remember
orthodontists
that?
again.
Do you remember
I
that?
hated that.
I remember that.
I hated that.
Yeah,
I never took out any second molars, I promise you.
I never allowed it to happen.
Yeah.
The problems from that was disastrous.
I
Now,
agree.
the second problem here is there's a really big bent to this data, and the bent is the lack of time.
Yes.
I have been practicing for 37 years, and I can tell you I'm one of those dentists that have those removed every time. Because in our culture, especially our soda pop and Captain Crunch culture, it is pure decay that happens to those teeth. The second thing is symptoms versus extraction status does not take into account orthodontic mistreatment. If those teeth are not placed correctly like they should be, you're going to have a big problem. And attachment loss does not take in the shrinkage of bone and gingiva and the ability to clean on the distal of those second molars. You will have a lot better attachment if you're able to clean on the distal of those second molars. Okay? All of these have not been brought up in our little study here. This study needs to go a lot longer and take in more parameters.
I thank you for those comments. I don't disagree with you. This study is not probably long enough to look at those caries and perio long term. We had 2 years. Greg Gilbert, Don DiNucci, we'd like to carry this out if we could.
So we can't bend this to the idea that perhaps we should save third molars just because of a little 2-year study that didn't take in all the parameters.
So my goal is not to save third molars. That's a far bigger cause than I'm willing to take on. But at the same time, I think what we should do is when we recommend third molars to be extracted, we should have good reasons. You've given some good reasons why third molars should be extracted, right? So we should keep that in mind. If you have asymptomatic thirds that are fully erupted and healthy periodontally, I don't know that we then have good reasons to extract those, right?
I had a question here.
Just to respond to that, my teeth grow in straight, and I loved the fact that I had the option of keeping them rather than just going ahead and just extracting them. And I don't have to worry about the 28% that ended up with pain in their jaw while opening wide.
This may go on for a while.
Aren't you guys hungry?
So mine's not a controversial point, but I was fascinated by the difference between the non-insured and the insured patients and their rate. It was about a 5% difference.
Yeah.
The question that I would have is, did you break out of those patients? Did you monitor what percentage of the patients had previous orthodontic extraction, particularly with 4 bicuspid extractions? Because there may be a difference in that insured group versus the non-insured group in their percentage of that group that's had that. And by changing the arch length and then reducing the potential for impaction because there's now some additional room for those third molars to extract, that could potentially impact those differences.
Could be a factor. We don't have information on whether they had orthodontics or not, though, unfortunately. Or you could probably get it.
Yeah. My question was, did you analyze on the TMJ problems whether the patient was intubated orally under general anesthesia in relation to the TMJ problems?
No, we don't have that data either, although I did do a study earlier looking at third molar removal in the Portland area and in the state of Washington. And in the state of Washington, a large majority of patients had general anesthesia, whereas in Portland, they were mainly treated under Kaiser. Most of them had just local anesthesia. Okay, so could be a factor, but we just simply don't have that data.
When you're asking the patients to answer these questions, when you're talking with 17, 18, 19-year-olds, how much do you think you're getting the real reason why they did or didn't have the extractions, and how much they might have asked their parents or got information from their parents on, well, we're going to do it because we have insurance coverage now, or we're not going to do it?
Yeah, certainly it's possible, although again, these 8-month surveys were done via email. They would click on a link and they would just answer it. So they didn't need their parents around to answer it, whether they, when we ask patients, when we ask patients to answer this, we always have to keep in mind that it is them answering and probably not their parents, and whether you can take their answer at face value for anything, right? You can always bring that up in any study. Can we believe what the patient records on there, right? That's always a problem.
Well, I think there's a lot of food for thought in this presentation. And speaking of that, there is food for lunch.
By the way, can I make one comment? And this is we are going to be working on this paper or these papers, and we would welcome if any of you are particularly interested to assist. Please let me know. I know a couple mentioned this last year, but at that time we were really not ready to prepare the manuscripts, but now we are. So if you are interested in that, please let me know. We would like to have input from you providers who treated these patients on the paper.
Okay, thank you very much, Greg. Go out